Everybody. Well, thanks again for all of you who support this program, the LHS Collaboratory. I'm Ed Hurwitz. I'm one of the co-directors of the Collaboratory as the Learning Health System Clinical Champion for Michigan Medicine. And I just want you to know today's session is being recorded and will be available at the Collaboratory website afterwards, so you can hear it again. I'm sure you'll want to do that. So thanks for joining us today. Again, the session is being recorded, and as I said, it'll be on the Collaboratory website. For anyone joining on Zoom, we kindly request that you keep your mics muted. We'll have time for audience Q&A, so please enter your questions in the chat. We will try and keep on with them to keep track of them. So today's speaker, pleased to introduce Dr. Robert Reid. He's coming to us from Toronto area. Dr. Reid is the Hazel McCallum Research Chair. Whoa. Hang on a second, Rob. The Hazel McCallum Research Chair in the Learning Health Systems and Chief Scientist at the Institute for Better Health and Senior Vice President of Science at Trillium Health Partners. He's a global expert and thought leader in population health, learning health systems, and primary care. He's best known for his work in developing and evaluating a patient-centered medical home at Group Health Cooperative, now Kaiser Permanente. Dr. Reid is currently providing expertise in the redesign of Ontario's healthcare system through the Ontario Health Teams Initiative. With IBH, Dr. Reid focuses on generating new ways to engage, design, deliver, and finance healthcare and creating partnerships with patients, caregivers, and the community to improve population health. At the University of Toronto, Dr. Reid holds an academic appointment as professor with the Institute of Health Policy, Management and Evaluation, and the Department of Family and Community Medicine. He's also a professor with the McMaster University Department of Health Research Methods, Evidence, and Impact, and an affiliate associate professor with the University of Washington School of Public Health and Community Medicine. And so that, I'd like to turn it over to Dr. Reid.
Nice to join you today, and thanks so much, Ed. This is such an honor to be able to come and speak to you guys today. I was just terrifically excited when Chuck reached out and invited me, and I decided to bring a pack. So we've got three of my colleagues are joining me. We made a short jaunt from Toronto up here yesterday, and we're looking forward to developing relationships with you. We're very close, and I thought there's a lot of synergistic work that we're doing together. So as Ed said, I am a scientist and have been leading the build of a really novel research institute embedded in one of Canada's largest hospital systems that is actually very close here, just a few hours drive in Mississauga. Trillium Health Partners is a large and soon to be the largest hospital in Canada system that serves about 1.3 million people. And it invested in about 10 years ago in building a new research institute embedded right within the system to improve the way it functions. So it's a bit of an R&D department in the system. And that's its whole purpose. So we've been leading the build of this in collaboration with the University of Toronto over the last 10 years. And I'll tell you a little bit about what we're doing in Mississauga and a little bit about what's happening in learning health systems across Canada. So that's the plan for today. See if I can move. Oops, maybe I'll need I'll need your help. Sorry. And today I've got three colleagues joining me. Walter Wadchis, he's one of our research chairs or senior scientists and a professor at the University of Toronto. Terrence Tang is a clinician scientist, an informatician that works with us. And then Shelley Vanderhoot is an implementation scientist who works at our research institute as well. So they're going to join me in the presentation in a few minutes. Okay. So here we are. If we can get this to move. Okay. Uh, in Canada, we usually start all meetings with an Indigenous land acknowledgement. And so this is the Indigenous land acknowledgement from the people in Mississauga, the Indigenous people in Mississauga. So I'll just quickly read this. The land on which Trillium Health Partners operates has been the site of human activity for 15,000 years. It's the treaty lands and the territories of the Mississaugas of the Credit First Nation. It's also the traditional territory of the Huron-Wendat and the Haudenosaunee. The lakes lands of this region, very close to here, continue to be home to many First Nations, Inuit, and Métis communities from across Turtle Island, currently known as North America. They continue to mobilize, live, and care for these lands and its inhabitants. People across Turtle Island have been confronted by the legacies of white supremacy. This includes a legacy of genocide, which Indigenous people have known all along, and whose demands for just action and justice have been ignored. It's also on this land that we've been confronted by the legacies and the current realities of anti-Black racism and slavery, the legacies of anti-ageism, racism, and indentured labor, the legacies of race and sexual and gender diversity, and the legacies of religious violence. And so this anchors the work that we do at the Research Institute, and really responsive to really undoing some of the harms they've been doing in many of our generation past and currently. Okay, so here's the frame for the talk today. I'm going to start off in just talking a little bit about how we think about learning health systems in Mississauga and increasingly in Canada. Just agreeing on concepts and definitions. We have a little bit different takes in different areas, and we can certainly have discussions on that. We'll present a framework that we've been using in Mississauga and has gradually been adopted across Canada that really is about the practical ways of trying to embed research right into the day-to-day operations of a large, complex health system like we have in Mississauga. And then my colleagues are going to provide 3 examples of current work underway of many different projects and work that we have. Okay. So this is the current state in Canada, and it's not a good scene in many respects. Healthcare is really struggling across Canada. And if anybody watches Canadian news from here or gets intersects with Canadian newspapers, these are headlines that you will see almost daily in any of the major headlines across Canada. Surgery backlog, staff shortages, no family doctor, new report highlights Canadians' healthcare crisis. I don't think I'll last how Canada's emergency room crisis could be killing thousands. Massive new survey finds widespread frustration with primary care. Canada's haves and have-nots lag behind Europe. Delays, falls, errors led to death, worsening care for patients in Manitoba hospitals. And patients taking up hospital beds while waiting for long-term care is a serious problem in Canada. So these are commonplace. And these are the issues that are plaguing Canadian healthcare. And the current state is really unsustainable. We have a system that was built for decades past and really needs to change in many respects. Care is fragmented, disorganized, access, quality, and costs are not optimized. The workforce is overlooked and devalued. Equity gaps, unfortunately, in Canada lives in a system that believes in equitable care. The equity gaps are not narrow, they're widening in our country. And we're seeing those that have the least are receiving less and less the proportionate share of resources. And Canadians are increasingly frustrated. Canadian healthcare used to be a source of pride for Canadians. They were very much pride. It was a defining feature of Canada. And now they don't, in many respects, believe it is there for them in the current realities. So we have to change if we're going to meet this reality. And this, you probably saw, this came out this year. This is the new Commonwealth Fund that rates nations. And I just pointed to where Canada rates. And in the industrialized world, we lag way behind many European countries in many respects in healthcare. So, and we generally look to Europe as our our beacon, and you'll see that in this survey, 7th out of 10th countries in terms of access and a whole variety of things. I won't point out where the US falls on this this access on this map. Okay, but this is not a source of pride, and this is not improving this specter every year as the Commonwealth Fund comes out with these reports. And this slide I pulled from many years ago, 2000, and this is often how it's thought is, well, it could be worse. We could be living in the US, so it could be worse. We could be living in Canada. And in many respects, both our countries need to really change and really change and do things. There's good things that are very much part of the fabric of Canadian healthcare, much like there's good things that are part of the fabric of US healthcare, and we can absolutely learn from each other on this. So we end up pulling our hair out and figuring out, like, how do we transition and how do we fix these multitude of problems that are facing Canadians? And part of the recipe is really change, and we actually have to change to learn. So there's been a real movement and a thinking about learning health systems and the adoption across Canada, from provincial ministries of health to the federal government to local places like our hospital system. And you guys are all very familiar with this definition of learning health systems. Of course, Canadians can't just go with the standard definition. They have to create their own definition. This definition came from McMaster, from John Lattis with McMaster, and it's very similar to the US definition with a few different changes to it. It's anchored in citizens' needs, perspectives, and aspirations, timely data and evidence, and enabled with a culture and competencies for rapid improvement and learning and improvement. But we're finding that even that definition is still lacking and needs to evolve. And one area that needs to evolve is addressing both equity, diversity, and inclusion, and around community orientation for learning health systems. So I think we're going to be proposing a new definition this year for Canada. So this is a slide that I probably don't have to talk to your audience about, this audience about much, but this is often what I'll present to academic audiences, is there's really often a real divide between researchers that often sit in academic environments, and then operators, managers, leaders, clinicians who work in health systems. And it's almost like they're battling sometimes between each other. And so, you know, here researchers, theory, evidence, drive questions. And in health systems, management and operations and problems drive the questions that they're answering. We like to give complex, nuanced answers. They don't want that. They want simple, straightforward answers that they can just implement and do. We want to design best feasible studies. They want something practical, simple, easy to implement. We always want to do it in piecemeal form, and they want to change everything right away. And then we typically want to avoid preliminary findings, and they want rapid, good enough answers. And so in this world, we work in this fray and really work to develop compromise and trust to get what researchers need to produce good evidence, but in a timely way that's practical for systems to evolve and implement. Okay, this slide is a slide that I use a lot in Canada. I don't know whether it would speak very well to you, but this is the way that research and care delivery traditionally works in Canada, is that they're very separate and distinct enterprises. Researchers sit at universities, and we think that care delivery systems just take up the evidence and it's magical. And we know that doesn't work. Okay, so that's the traditional way of thinking. In Canada, over the last 30 years, we've been on a journey of what's called knowledge translation and exchange, which is really, in my thinking, just a brokering function now between the two enterprises, where we broker the questions that are asked with engagements, and then we broker the dissemination activities at the end of it. And that's improved this considerably, the divide But learning health systems, in my mind, is now just an evolution of this concept where we're really now just embedding research right into the day-to-day fabric of healthcare delivery and policy. This is another slide that we use all the time in Canada, and it's really to talk about the partnerships that are needed into health systems. And we talk a lot about health system partnership and research partnerships, but often we forget and don't enable citizen, caregiver, community partnerships. And this slide was created by one of our patient partners who really said, this isn't a steady stool. This is the weakest leg. And we need to spend considerable attention around building up the capabilities for patients, citizens, caregivers to have better voice in the learning activities forward. So this was her slide. We don't often talk about what systems are. That's the other part of learning health systems. So I just wanted to quickly think about what my definition of a system is. And so when I think of a system, I think of a vertically and horizontally integrated system that integrates the suite of services from primary to long-term care, across sites, providers, and over time, delivers them that are person-centered, not disease-specific, accountable for whole populations, not just people who come in the door. So everybody in Mississauga, that would be 1.3 million people, many of those that we don't know very well. We address all quadruple aims, and we'll get into that in a little bit better. We address medical and non-medical determinants of health, so it bridges outside of healthcare to health. And so you could certainly think about a word like including transportation or city services in how you deliver care. And then it's integrated by data, governance, financing, IT, personnel, and so forth. Okay, so that's how I think of it as a system. And that's not what we have in Canada. Not what we have in Canada. We don't have an integrated set of services. We have a hodgepodge of services in general. We often don't deliver things in person-centered ways. We don't have integrated functions like this. And we often don't focus on broadly across non-medical determinants of health as well. So learning health systems is actually about building systems in Canada. It's not just about improving them. It's about building. Okay, another slide. This comes from some work that Mike Manier did in Montreal, and it's really conceptualizing layers of learning. And we use this a lot too, and making sure that we know the layers of learning activity that need to occur. Clearly, there's learning that has to happen at the patient-clinician level. So the evidence today could be used tomorrow. That today's experience can contribute to the big body of evidence for tomorrow's decisions at that level. That's not where we focus on. We focus at this meso level about how to organize, how to finance, how to deliver care at that level. But there's also activity that needs to happen at the senior levels around how to finance, what are the policies, the regulations, all of those types of things to facilitate all of those to occur. So we have work going at our provincial ministries of health and the federal government to really enable learning to how we do those facilities better. So this is helpful because people see themselves in different places here and it doesn't get confused. Okay, of course I couldn't come to Michigan without putting up this slide, and I tell you how important this slide is to the world. This has been a real anchoring thing around thinking the ideas about learning health systems and about using data, creating knowledge, having cyclical learning. And the work, Chuck, that you've done over the years has been, we've built on much of that work. And over time, we've seen many different iterations, frameworks, models that have occurred to try to facilitate. This was a work that Sarah Green and I did many years ago in Seattle, but many different types of frameworks. And they're all useful. We find different uses of them, but we found them actually often not practical. Like, what does this mean you do? How do you organize yourself? How do you relate in a health system? how does this practically come to life? So while this was useful for us, designing a really novel research institute didn't give us a lot of direction around how to do it, particularly what the type complement of evidence that we wanted to build, and what the relationships with different parts of the health system needed to be. Where did our scientists have to interrelate with different people in different groups? So we've been on this journey to actually figure out how we can tell our story, talk about what we do, and really help the organization and our system understand how we contribute to improvement. Okay, if that makes sense to you. So we've created our own framework for learning health systems. It's very practical, that we use all the time now, and it's been very helpful for us to kind of get movement and traction going forward. And it's built on these frameworks, like Mike Deere's framework. Okay, it kind of helps us sort through the practicalities of this mess. So I'm going to talk a little bit about this framework quickly, and then we'll get on to giving some examples around its use. Okay, this is the learning health system framework that we developed in collaboration with our researchers at Trillium and researchers across Ontario, including patient and family partners. And it's positioned as an engine. And the reason it's an engine is because that was understandable to patients and clinicians. They got it. They understood what an engine did. They understood how an engine needed to work. And so the reason it's using this as the analogy is because this could be understandable to patients. And you'll see at the framework that there's a bunch of internal gears that really specify the sciences and the evidence types that work in harmony together to produce learning. They rotate and they produce quadruple aim metrics with equity as a fulcrum. And the reason that it's there as a fulcrum is we believe that equity is an overarching concept. It's equity in affordability, equity in quality, it's equity in sustainability and in population health. So equity is central, and then everything here has to have an equity dimension. That's why I brought just those sides. So the engine is fueled by things. It doesn't go by itself. It's not a virtual thing. It has fuel and accelerants that prime the pump and make it go. And these have to be built and sustained to make this engine work. And then it has brakes and moderators to keep it on course and in the right direction. And people will talk about these as barriers. I don't view them as barriers. They're necessary, such as privacy, law, governance, ethics. Those are things that have to be in place to make this work. So that's kind of the overall framework, and we'll dig into it in a little bit. There's lots written about it. You can hit the QR code and read more about it here. Now, in Canada, you have to do everything in French. So this is the French translation, but I'll skip over this. But it's also now produced in French to be used across Canada in the second official language. So we talked a little bit about the goals of the system. I won't go into that a bit, but I will spend a little time talking about these gears and what they are and how they work together. And the first is really around data and understanding the nature of the problems. And so this is using advanced data works, both quantitative data, qualitative data, machine learning, advanced qualitative methods to really understand the problems that we're facing, the equity dimensions, the reason that are underlying those problems, because we often misspecify that and we're solving the wrong problem. We talked about that this morning, that sometimes they're social problems that we're thinking we're solving with a health system. So it's really trying to understand this problem. The second is really rapid cycle evidence synthesis. And in Canada, we have the luxury of having wonderful evidence synthesis shops that really do rapid cycle scanning, environmental scanning, being really heavy duty methods to understanding what's been tried somewhere, what's worked, what hasn't, what are the conditions that make it work, what are the enablers, so that we can really understand what other people have tried to fix these problems. And then we bring these two sources of evidence together into co-design work. And this is now, we bring patients, caregivers, and providers right into the co-design work. And now this is using the new sciences around co-design and user-centered design fully into this mix. And really making sure that we're lifting the voices of equity deserving groups that are often disadvantaged, to making sure their voices are heard in these co-design events. And we can do this rapidly now with our health system to do this type of work. The third, and this is the fourth, is, you know, you can design the best system in the world, but if you implement it in a half-assed way, you're not going to get the outcomes you want. So this is really around bringing to bear the science of implementation, science that has exploded in the last 2 decades. And then there's rapid cycle evaluation and feedback with rapid information provided back to teams, because nothing ever works the first time. You always have to modify it. And so this is about rapid cycle evaluation. And this is the work that Walter leads for us. So that's the essence of what this looks like. I won't go into these fuels and accelerants, but we've spent a lot of time working on these. And the first one is really around developing leadership capabilities with our senior leaders in the health system for rapid cycle improvement and change, and developing some understanding of research methods with leadership. The other ones are engagement fuels. And so it's patient, family, community engagement with equity deserving groups, including Indigenous Canadians and the workforce. So those are the engagement fuels. And we spent considerable work around developing those engagement fuels and understanding how to bring in all those groups into the work that we do. Scientific expertise, funding, data technology, implementation supports, and then developing learning networks. And this is what Shelley is leading across Canada to develop a learning health system, learning network. So it's not just at Trillium, but it's other hospitals across Canada. Oh, I forgot about this one. You know, health systems can't do everything at the same time. They have to prioritize stuff. And so we really actually have to understand what their priorities are and be able to really link with them. So it's developing capabilities around prioritization of work. Okay, I won't go into this at all, but these are the methods that underlie these things. So these are where we have scientific expertise that is now built into each of these gears in our research institute, okay, to do this type of work. And as I say, equity, and we are still on a journey about this, of making sure that we're building it into all work that we do and deliberately addressing equity in the patients that we're recruiting, or the data that we're collecting, or our co-design events, or the evaluation frameworks that we're using. Equity needs to be evaluated in everything. Okay, so I'm going to stop in a minute, and then I'm going to hand it over to everybody else. But I want to tell you a little bit about Trillium Health Partners before I do that, because you're going to hear a little bit about the environment of the health system first, because this is where we work. So this is just a specter of what Trillium looks like. As I say, it's one of the largest hospitals in Canada, in Ontario right now, which is the biggest province in Canada. It's the #1 inpatient activity, and it has more ambulatory visits than any other hospital, delivers more births than any other hospital in Canada, and has #2 in terms of surgical cases and emergency room visits. So it's an enormous place. But there's huge challenges to Trillium, is that there's at any one day, there's about a 200 bed deficit. So today in the hospital across the river, across in Ontario, there's about 200 patients sitting in a hallway that have been admitted to the hallway because there's no place for them. Okay? That's not a good place to deliver care. The capacity constraints are crucial, and they're ever growing because the community is growing at such a rapid rate. There's fewer long-term care beds at Trillium than in any place in the country. And so our hospital has got a lot of patients with long-term care needs that can't go home. And we don't have anywhere to send them. Okay. It is one of the lowest home care resources in all of Canada, 10% less than the national average in terms of home care resources in there. So it is a system that is stressed and is in crisis in moving forward because of its capacity constraints that it's facing. And there's nowhere else for these patients to go. There is no other hospital. This is the only place for these 1.5 million Canadians. Okay, so and it's only going to get worse. 45% growth in community in the next few years, with 101 million new residents expected to come to Mississauga. The explosion in seniors, more and more patients from all over the world. 50% of residents born that are in Mississauga were not born in Canada. 130 languages spoken there, like the world. And unfortunately, it's getting poorer. And so the 51% of the people now live in poverty in that city. So this is this is a signal that we really need to change. And they are changing. This is the new hospital that is currently under construction in Mississauga that will become the largest hospital. It's 27 stories when it opens. And it'll dwarf every other building in Mississauga. And that will be the largest hospital in Canada. But even when it opens its doors, on day one that it opens its doors, if we keep doing the same things, it will still be 200 beds short. It will still be 200 people waiting in those hallways for a hospital bed. As that capacity, this red curve is our demand curve that we see growing and growing and growing. And then this is the capacity curve of the new hospital being built. So that's the crisis. So that's where we come. Can we solve this problem? Can we help the community shrink this gap? Either reduce demand or somehow increase supply in other ways. And this is the curve. This is the graph that everybody at the hospital, all senior leaders know by heart. And the CEO uses this every day to tell us why we're here and what we need to do. So this is the strategy for the organization. I won't go through this at all, but it's really not doing things the way we are. A new type of healthcare for a healthier community, meaning expanding beyond the hospital walls and doing things very different. So with a focus on things internally, building the systems, and then improving the community. So that's the strategy. And I think you can figure out every one of our work fits somewhere into that strategic plan at the organization. Okay. The research unit was established 10 years ago now. And this is just a picture of Walter, me, and a couple of the other senior researchers. And it was an article that was written by the University of Toronto. Very easy to read article if you want to read about it. But it's really about how we are built for purpose to solve those problems for this hospital at this moment. And now we have how many faculty? About 20. Specifically, we have about 25 PhD and doctoral scientists working with us now have a budget of about 16 million Canadian yearly. So over the last 10 years, we've had substantial growth. And we have one of your people working with us now, Victor Rentis, who is just a terrific has come and joined our group last year. Okay, so Walter, can you start with an example around hip fractures?
Sure. I'm going to do 3 little super rapid fire summary examples of the ways we're actually evaluating this. So I'm a professor at the University of Toronto. I'm actually did my PhD here at Michigan in the School of Public Health. And I came to Trillium to learn from Rob once he had moved there to learn about how do we actually do this. And so I spent a fair bit of my time making mistakes, frankly, learning how to do this really in practice and not just write about it in articles. And so I'm going to talk about not the mistakes. I have to talk a lot about those afterwards. Just one of the 3 examples that we want to cover here. So you've seen this. We're actually trying to drive the quintuple aim using these gears. I'm going to talk about one of the ways in one project that we're doing this. We have many of these happening. This is just one example. So I'm going to work through the 5 gears. One is starting with this idea of population health analytics and evidence synthesis. So one of the things, I'm going to talk about hip fracture as our example. And we found by looking into the data of, hip fractures are very expensive things that happen to people, and Trillium performs quite poorly in this space. And so that's how we use the data to identify this as a priority area. And then looking for evidence. So what is the evidence around? So there's a whole host of evidence that we did review bringing into this, but one of the most important and salient ones is the Ontario Ministry of Health has practice guidelines that every hospital is expected to proceed and follow clinical handbook for hip fracture. So looking to that and what those standards were relative to where we were performing. So this is some of the examples. So in hospital mortality, we were at like 6.4%, which was 19th out of 20 peers. And we consider ourselves to be one of the best hospitals, and we are the 2nd worst in that ranking. Wait time surgery within 24 hours, one of the key markers to do well, we're 19th out of 20. We are 29% of our patients are hitting that mark. So just the whole host of other things, pain management and other things that we're monitoring, but just 2 salient things, and particularly mortality. Before we had that one, orthopedics were like, we're doing a great job. Don't mess with my elective surgeries. But once you stick something like that in front of them, like, oh, people are dying. Oh, okay. Well, maybe we'll pay some attention. So, different ways of communicating. We're also losing money. Total cost that Trillium was incurring was $20,500 per case, and we're only getting 16,000 cases. So we're losing about $4,500 per case. So again, getting other people online and what's important to people and understanding what's important to people to get them to make decisions. Caregiver and patient co-design. We had already started to do some work in understanding people with hip fractures waiting after their care to go on to their next care setting. And we have a couple papers. This is just one example. The BMC Geriatrics recommendations. This is the title of the paper. Recommendations made by patients, caregivers, providers, and decision makers. So hear about all of those different groups that we brought together here to improve transitions of care for older adults with hip fractures, the qualitative study. So this is the kind of research and evidence that we're also building into the co-design of how we work with people and make sure that what people have already said is front and center. And this was research that was done at Trillium. Area that I work in mostly is this implementation and evaluation. This is my research chair's title, has that in it. So planning for implementation with active involvement, engagement, ongoing supports, and rapid cycle feedback. So how do we get things coming back in meaningful ways to each team? So we have like data systems that we've built up, and we have some really great supports at the hospital system for doing that. And then the whole hip fracture team gets these. These are like monthly reports, sometimes bi-monthly, depending on what's happening. And they talk about the things that are being implemented that month and the data that's being achieved. So we actually see on here, and I'll show up, you see some graphics that actually come back to the team. So not just some online dashboard, we have these too, but like newsletters that are getting pushed out to many people. It's easy for many people to see this visibility. And I'll just give up, these are 2 markers. So I talked about the time to hip fracture surgery. So 2023, it was 42. That was the median time. And in 3 years now, we've got that down to 27. So we're getting pretty close and we're definitely making progress year over year. This is in that newsletter. So we're not just talking about, hey, people are doing fun things. No, we're actually providing data back in a pretty widespread way, as well as the length of stay. And we haven't yet put up mortality numbers because you have to appreciate they're still relatively small numbers. So we want to feel we have a pretty good track record on that. So this is just an example of how we've actually put this whole kind of piece together, living with the people who actually have to make this change. I can't do anything, right? I just need to support people in ways that make it real and lively for them to be able to make some of those changes. I think, Terrence, you're going to talk about some of your.
So I'm one of the clinician scientists, and I'm an internal medicine physician who works 21 weeks doing clinical work in the system. And the other half of my time, I am a clinician scientist within Institute for Better Health. So I can see that in action every day. And I'm going to show you an example, something that's in my program, the medicine program, about care transitions from hospital to home, and how a medicine program, I take that using a learning health system approach to try to achieve some outcomes. Rob has already gone through the context, so I'm not going to repeat a lot of it, just so you know that we are almost constantly 120 capacity, and people being cared for in hallways are the reality. And in a system like this, anything to improve throughput, obviously, is a system priority. So there's immediate alignment of why health system would like to participate in any efforts like that. And we also, and the medicine program in particular, has a strong relationship with researchers in IBH to embed a learning health system. So similar to what Walter has talked about, we use the first learning gear using analytics and population insights. We're fortunate enough in Ontario to participate in a provincial initiative that actually collects data about inpatient medical care and actually can benchmark against our peer hospitals. And this is some of the things that we are able to see how we're doing compared to other hospitals and trends over time as well. I'm just showing examples of one of the indicators, but there are a number of indicators. The medicine program actually has some kind of insights from their own data saying that they are actually, our length of stay are actually increasing over time rather than being more efficient. And we actually compare against what other people are doing. We see similar trends across the system, but we also identify that there are actually ways that we could actually try to improve that metric. And similarly, in the provincial context about care transitions, there's actually quality standards put out by Ontario Health, which is kind of a provincial agency, about this quality of care that's expected of hospitals in Ontario. And from looking at those standards, we know that we have actually areas for improvement that could be improved on. And then for the third learning gear about patient, caregiver, and provider co-design. So knowing what needs to happen, what are the current gaps, through a CHR funded project, which is one of the federal funding agencies, we are actually participating in a multi-site study about how to improve care transitions from hospital to home using digital tools as well. So the program worked with researchers and we spent a lot of time in co-design with our patients and caregivers, in-hospital clinicians, and also in the primary care sector, which is we don't work for THP, but work for work outside the community settings. And we bring these people from different professional backgrounds and different sectors in the system together to think about how we can improve the care transition experience. There are 9 challenges that the co-design group has identified. And I won't go through the details, but I want to show you how this all works. And it's really important to bring patients and caregivers into the work, because when we show this, what we learned is that when we show this, like when the healthcare teams are hearing from patient and caregivers, what their experiences are, they actually can see it in their day-to-day work as well, and they didn't like find that to be surprising, and actually we're really invested in actually improving the experience. And similarly, we also learned that patient and caregivers are very reasonable about expectations and actually understand that clinicians sometimes busy and they don't expect things that are unrealistic either. So we learned a lot from that experience as well. And then even though the study is about using digital tools, we also know that digital tools can only work with embedded workflows. So the co-design piece is extremely important to make sure what we design actually will be able to be implemented in real life. And we actually, through the co-design process, we actually changed the way we envisioned how the technology was delivered. We actually decided, because of technology context to embed the functions in our new health information systems that was implemented recently. And then we're in the middle, and then in terms of implementation, this is co-designed with the medicine program. We're actually addressing the challenges that we learn from co-design with patients and caregivers, and then different units actually are working on addressing each of them with different ways to make it feasible, to make the change actually able to be sustained at a local level. And then we also, through this multi-site study, actually are collecting both quantitative and qualitative data and understanding how it impacts the equity-centered quadruple aims as well. We are about to implement this month, and we have completed baseline data collection at this time. And this is just an example of how it can happen in real life. So I'm gonna introduce Shelly come up and talk about from there.
All right, so my example is a little bit of a different twist than those of Walter and Terrence, but I'm Shelly Vanderhout. I'm a learning health system scientist at the Institute for Better Health at Trillium and an assistant professor at the University of Toronto in the Institute of Policy Management and Evaluation. I'm a registered dietitian by training, actually, but have jumped through a few different roles and landed here. And one of my main focuses is on community and patient engagement in learning health systems. So we had the chance to chat this morning about what that looks like across different health system contexts, and really just the importance and the centrality of this focus on community partners and citizen partners. So today I'm going to speak about a very recent project that I led with some colleagues at the Institute for Better Health about creating an arts-based resource in everyday language for citizens to understand what learning health systems are. And so Rob touched on this a few moments ago, but really there are so many learning health system models that show this centrality and this focus on communities and patients at the core, and really hearing their voices and their perspectives and priorities. And we see this in so many models, including our own. But in actuality, little has been done to actually help the public understand what a learning health system is and how it relates to their experiences, and then how they can become more engaged if they'd like. So our objective was to work with citizen partners to create this everyday language resource that would help the public learn what a learning health system is and how it relates to their experiences. So we held 2 virtual workshops in the fall of 2024 with 13 citizen partners from across Canada. And these were folks that were kind of peripheral or within our existing networks who had at least some knowledge of a learning health system or some experience engaging with learning health systems, but still really maintain that sort of everyday person perspective that would help shape this work. And we held informal discussions to agree on, how do we co-envision a learning health system? What does it mean to the everyday person? Why is it important for the public to learn about learning health systems and what they are and what they strive to achieve? Who would be the target audience for this resource? What should the format of this resource be? And then finally, what are its intended impacts? So I'm just sharing with you a very draft preliminary version of the arts-based resource that we co-developed. We partnered with a graphic designer to produce this. And we landed on creating a comic strip that will come with annotation, but I just blew it up for you for clarity here. So we decided as well on a central experience that many people could relate to, which is being in the emergency department and kind of having this sometimes frustrating, exhausting, confusing experience of waiting a long time and just really having a poor experience, of course, in the midst of a health crisis. And then we transitioned sort of to the opportunity to provide feedback and to share those experiences. And then a further opportunity to be invited to a team, a multidisciplinary team of researchers, health system leaders, clinicians to say, okay, what can we do to improve? And from all of our perspectives, what would this look like? So you can see then we shift to sort of a roundtable discussion, multiple perspectives being shared. Then an implementation scene where either a service dog or a support worker is there to help try to improve that experience. And then finally, sort of an ongoing dialogue and iterative improvement over time and evaluation. So on this slide, I've just broken it up just to show you as well. We did use the Learning Health System action framework as a guide, and we tried to sort of create different panels that respectively follow this framework, just to showcase how this works in actuality for that commonplace perspective. So with this resource, our envisioned impact is to first promote a common language around learning health systems, of course, with the public and everyday citizens as our focus, but also within learning health system circles. That's something that we hear time and again, that the language and the terminology that we use to describe learning health systems can be so varied. Also to build trust between health systems, researchers, and the public, especially where reparation is needed. And finally, to widen the community of citizens who are at these tables in learning health systems. We hear a lot about the usual suspects or the people who are there time and again, but really to broaden these perspectives that we're hearing. So I'll be sure to share the final version with you once it's ready, but that's it from me. So
Thanks, guys. So that's it from us. This is a site where you can post all the materials for all these things you want. And it was great being here. So any open to any questions or thoughts? Yeah, is that next? Okay.
Anyway, questions online. Any questions in the room?
Hi, I'm Gretchen Platt.
Hi, Gretchen.
I'm the chair department. I'm curious. I think this is fantastic. I mean, I love the way that you presented everything. Can you talk a little bit about how the work is funded?
Sure. It is a challenge on this because applied work like this is hard to fund, particularly the scientific component of it. So there's kind of three real pieces of or 3 or 4 real pieces of work that we get money from. We compete like you guys do for federal research dollars, and the Canadian Institutes for Health Research, one of their priorities this year or last couple of years is learning health systems, and there are individual calls for research like this. But you know, it is very competitive, hard to count on, and so forth. But we've been pretty successful in that area. So today, the second is really around philanthropy, and we rely a lot on philanthropy and the generous donations of Mississauga residents who don't really want to fund. Who their objective isn't fund research. Their objective is to fund change and to fund improvement. They really want to see the system in Mississauga improve, and they know they're very savvy and know that we are part of the recipe for success in that, and they're willing to invest in that. That's the second piece. The third is actually the health system itself. Often it is funded to do project work by the Ministry of Health and that sort of thing. And part of it is that they can reserve some of the funding for project work for evaluation work. And so we do get money directly from the Ministry of Health to do work that promotes the work at Trillium. And that's so we often will co-apply for provincial and federal money with the system. And then the fourth is industry. And so we do work with industry sponsors, particularly informatics groups that will come in if they want their tools used, understand how to make them applicable in our environment. We will derive some money from that. So those are generally the sources, but there's never enough.
Rob, here's a question from Greg Merrick, who's very involved in patient engagement.
Yep.
Curious about rural and poverty in Canada and the degree to which this patient population is integrated as authentic patient partners involved in the entire life cycle of research. Also, to what degree has funders been responsive to compensating patients before projects are funded?
Yeah, it's terrific comment, and it's very apt. I mean, Mississauga itself is pretty urban. We don't really reach into the rest of Ontario, which is really rural. So many of our partners are really rural. But regardless of the rurality stuff, there is a tremendous heterogeneity and socioeconomic status even within our own environment. And so we do really reach out to recruit patients, build them in, and we often do actually have to compensate them. To particularly those that are of less means, we need to bring them in. So we actually have at the Research Institute developed a pay schedule for research partners, patient research partners that we now use, and so forth. So we are actually valuing their participation, and we're challenging the status quo at the some of the agencies don't necessarily see funded patients as critical, but we challenge that. And I think the tide is changing.
Here's a question from Danielle Newsbrook. I'm very curious about the Canadian perspective on the role of AI and deep learning models in learning health systems. Is leveraging AI and integrating advanced AI methods directly into the work streams for both providers a priority? And what goals exist around leveraging AI to decrease provider burden and improve care delivery in Canada?
So maybe I'll let Terrence answer this one a bit because he's a little bit more applicable to it. But AI is deeply embedded in our and we are actually coming out with a real AI strategy and building more capabilities in the Research Institute around advanced analytics and AI. But we're very cognizant of the fact that often AI models and AI is often derived from populations that are not like ours, and that actually may harm particular segments of our population. And so we're very cautious around the use of AI models from other places, and often we'll need to replicate, use them in our environment, change them as they're needed, and we're particularly concerned where the data that's fed in them is underrepresenting equity deserving population. And how do we be cautious around the use of those things? I mean, Terrence, do you want to add anything to that?
Yeah, so I think we are still in very early stages, but we are definitely heavily like one of our colleagues, Fan Fine, who's a vision scientist as well, is very heavily involved in developing the methodology of shaping the AI strategy for the organization of setting up governance, especially for AI terminal partners, so that we actually have proper governance around using the technology. We also have an AI vendor that engage with, that trust. So we are like, I think in the next year or two, we're going to develop a bunch more capabilities. But I guess we'll do that.
Great. Yes.
Hi, Ben.
One of the things about Canada, those of us in the US both envy and wonder about is in the US, it's kind of a free-for-all for healthcare systems. At least you have eventual coordination at one level. So it's some semblance of uniformity, at least within the province. To what extent is your system working in Mississauga as you do research? So what are the issues about generalization within Ontario and then generalization across the other provinces? How do you deal with those issues?
Yeah, so it's a really good problem. It's a really good question, and most of my career was spent in the United States in Seattle. I'm very familiar with the problems of the US, in particular the different things and what that can do, and the effect of uninsurance. I mean, in Canada, the good thing is that care is, at least hospital and medical care, is at no cost to any Canadians. So they pay no payments. There is no cost for the direct for healthcare. That's one of the things in Canada. the problem in Canada really relates to capacity. So, you know, whether you have insurance is only conditional whether you can actually get care because of that insurance. And if you have no access to primary care, there is a shortage of primary care physicians, or you're waiting in emergency rooms. That, you know, that certainly dampens down what you could get from healthcare in Canada. And that is very uneven. Very uneven. So there are many places that is more rich in its supply, other areas that are not, and there's historical reasons because of that. In Mississauga, it's because of growth of our community, and the pace of the growth of the system has not kept pace with the growth of that community. That's our problem. And every setting has its own problems. And so this is the beauty of, I believe, networks and learning systems is we don't believe that the things that we necessarily invent at Trillium could be applicable in Thunder Bay or in the northern parts of Canada, where their challenges are very different, that are very different. But yet there may be clues in what they're doing. They can use what we've done and modify it for their purposes. So it is a real conversation across Canada, but we don't expect that there will just to be a cookie cutter effect from community to community. Walter?
Just add one thing. I think like generalizability of the actual work is rarely transmissible from any system to its neighbor system. And I think what we're trying to understand is what is the approach, understanding, and undertaking solutions to the problem that we're addressing. And I think that is generalized. So I'd say it's what mechanism, what particular pathways you put in place may or may not apply. So, you know, what can we learn from others? But the approach to doing things is we are trying to get people onto the same path of approaches to doing things. That's what I think.
No, thanks, Ed. This is really terrific. I want to talk to you about writing 5 papers. But that's for another time. As you've been talking, you see virtual steam coming out of my head.
Oh, no.
It's because
Oh, no.
I've been trying to map, as you've been talking, your vision of learning health systems with the one that either we have evolved or that idiosyncratically exists in my head. And one word that we use frequently, you haven't used, and this isn't criticism, it's just a difference. The word infrastructure is so central to our thinking. It's in the name of our PhD program, health infrastructures and learning systems. And so I want to ask whether you all use this concept in any way in your thinking about learning health systems. The best I could come up with is that there's another layer below your gears, and that there's a little motor driving every one of those gears, and that's an infrastructure that clearly exists in your environment, but maybe isn't part of your model. But let me ask what you think about all that.
You know, it's a good term. We don't use that term particularly. It's not a common lexical, and it's mainly because infrastructure means different things to policy makers in Canada. It's about capital buildings, hospitals, and those types of things, information systems. But generally, we have not used that term because we need to make sure we don't confuse it with what systems do. But I think you're quite right. Under the gears are a lot of assets that we've been building, processes, people, making sure that we're getting our people into the right mixes, capabilities around building culture, things that are under those gears that I spend most of my time involved in. And we haven't been explicit about what that looks like. But I think that's what you're really by infrastructure. Yes, we should write about. Does that make sense?
Yeah, that's perfect. And your point about confusing people with the word infrastructure
is something we've faced a little bit because when some people ask about our doctoral program, they say, "Is this about building hospitals?"
Yeah.
And things like that.
And we're building the biggest infrastructure building.
Right.
And there's the Ministry of Infrastructure, so we don't want to get confused by all of that.
Sorry.
Everybody here knows that Chuck and I looked at these Chuck and Chuck loves these me. I wanted to comment that I didn't miss infrastructure because I was translating things that he wasn't making explicit in our language. On one of your first slides, it had infrastructure as the lowest entry. But when you looked at the facilitator support, the leadership, the social context, down below the governors, the ethics, everything we talk about in social infrastructure, he's got all the pieces, but he doesn't pull them under a label the way we do. And I think your point, Chuck, is to say that I agree with you.
Oh my God.
I think if they pointed these pieces out for the social infrastructure that supports the system and the meeting with what we do.
So a really good example is our community that we have the ability for us to reach deep into our community partnerships and how we do that. We have really good relationships with, for instance, the Black Buffalo of Mississauga, the Roots Community Health Center, which is a something groups, and there are structured ways that we relate to them and how we do it. That's an example that's not called out specifically.
We're not called out as an infrastructure.
As an-
I definitely make that translate. Right?
Yeah.
And part of it is like, we're deciding the things we need to do and what are the infrastructures we need to put in place. We're still learning about that, I think, as we go, to make it scalable.
If I can just add, if you put social infrastructures in front of it, maybe because most of the people doing this work are focusing on the social side.
Yeah.
And we just assume that when we talk.
So maybe that is
Yeah.
We use socio-technical infrastructure.
It's a good point.
It's a good point. The one challenge we have is, the hospital also has its infrastructures, and part of it is how do we work together with them on maximizing the joint use of these infrastructures. So, for instance, our patient family and community engagement infrastructure, why are you doing it separately than hospitals? Could we not do that together? Same with all of our infrastructures over data analytics, the community analysts, so we bring that those groups together. That's been a dialogue around how we integrate these groups rather than separate.
A question for Josh Rubin. Given that equity is a fulcrum, I'd be curious to hear more about how equity is defined and measured in this context.
It's a really good question, and we could come back and spend a whole presentation on equity, and maybe that's the next presentation we should do, and I should bring some of our equity experts along with me to define that. Equity is really we are evolving the concept of what equity means here, but it is really lifting up those people who are less able to, for a variety of different reasons, and don't have the social advantages that others do. And that's pervasive in Canada. And part of it is understanding where those inequities are. And so we are progressively starting to divide out all of our patient populations or our staff by different equity deserving groups, and really understanding the interplay with equity on all of these things. How equitable is our patient advisory community? How equitable is even the faculty at our institution? How equitable is the care for hip fracture, for instance? And one thing that I can say that the Institute has done very well is really develop some common metrics around how to do this. And one of our other real main colleagues, Laura Rosella, has created a standardized equity measure for every hospital performance measure at the hospital. Every performance hospital measure now has an equity measure attached to it. So it's not only looking at what the mean is, but it's looking at the variability by these different equity characteristics. And it has uncovered a whole bunch of inequities that before were opaque, no one knew about. And now there is it is actually requirements for fixing many of those things in the program. So that's part of the work that we've done this year, is developing a common framework for measuring equity. And that was just published. So we should get the article that shows that.
But in
Anything
real world,
that-
that's the board, like the board meets monthly, we see equity reporting across
Everything.
areas, and that's it. It is. That's right. True.
It's in experience, it's in staffing, it's in all of those areas.
So I wanted to ask that there's a lot of the data that we talked about here, it's pulled by hospital administration, pulled kind of automatically.
Mhm.
Patients register with their gender and their race and so forth. Where in any of the work you've done, have you caused the clinician to change their workflow to actually get involved in this and how they enter data? And how have you succeeded in getting them to engage?
Maybe that's a good question for, because you work with your colleagues all the time.
Yeah, so we have to do all that. So I think there's like a big work. Rob mentioned there's work about like working on communities to understand how best to collect this data. So when we implemented electrification systems back in 2020, we are collecting elements for the fields, but we do not routinely collect about the patients that register at our institution. But there are actually very focused work on how to do that sense in a meaningful way that you need. I think there's some like thing that will come on like June of 2025, that there's plans for doing that. Like currently, because we believe that if we collect the data, we have responsibility to do something about it, unless we are willing to unless we are at that bar.
Are there other examples other than equity data that we're engaging clinicians or like novel ways of collecting different things? I think.
Yeah,
Okay. Anyway, it is an area where I think we could do a lot more, because we have just, the good thing about Trillium is we've just implemented a large electronic medical record across all of our sites. Electronic medical record that you probably know. And you know that it's complex to implement, and parents led part of the implementation of electronic medical record. So we have that in place now. And now it's actually maximizing its use, and we know that we are not collecting the best data most advantageous. So that's a.
And also there's also provincial requirements. There's certain programs like Reid, for example, that require to collect those data. Like so, like we are meeting on provincial standards for data as well. Yeah.
It always helps to have provincial, mandates. Okay, first question for Walter and his implementation role from Sarah Green. Implementation evaluation role. Are you tracking and monitoring the cost of implementation and or de-implementation as you embed initiatives and undertake the projects?
Yeah. So I'm glad you have the mics set up here that they can hear for more I'm standing. I presume you can hear the answer. So that's a very good question. We could back out, we haven't explicitly tracked, but we can back out incremental implementation costs. In certainly HIPRAC is one for sure. We've done some virtual support to community that we could do as well. Maybe not all. We haven't done any obvious de-implementation that is top of my mind. Like we need to create space to do this work, and can you recover those resources back in terms of incremental? In other ways, one of the ways I would think about this is we have an ongoing implementation team at Trillium, and it's a little bit about, are we optimizing their value? And that's in the scanning and identifying the priorities for improvement. And, I sort of have a bit of an approach of thinking about this as we have a high burden problem with a considerable gap in care. There's evidence to meet that gap, so we kind of know what to do to fix the problem, and people are willing to go. If we line up those things, then we go. In the hip fracture, we had the first 3 for the first year and a bit, and we didn't have people willing to go there. We hadn't yet quite made the convincing argument that it was worth fixing the hip fracture, the urgent care problem, when it was going to disrupt the planned care profitable problem. And so we kind of kept that at the background and worked on some other pieces in the middle. But it's a good question, Sarah. We don't methodically track it, but we do. It wouldn't be hard to back it. Right now, it's about we have a resource and we're allocating it to the best use.
I just want to comment to the team. There's a comment up there from Dr. Pauly. Dr. Pauly is the one of the executive leaders of the medical center, and he's been listening in. He says congratulations to the Trillium team and Dr. Reid for the wonderful work you're doing, and thank you for sharing experiences. And a note to myself and to Dr. Piet, it would be good to have a follow-up conversation, which we will do. Other questions?
Another area where I know we had a discussion today is a lot of we work is on a kind of helping the health system, particularly the leaders, managers, vice presidents, directors, understand what we do, what the contributions are, and what the role of research is in care delivery. So we spend a lot of time with my senior level colleagues around really helping them understand the role that we play, often in partnership with the Quality Improvement Division and the performance management and business analytics divisions of our institution, and making sure that we're there. We've recently developed a training program using our model for managers and directors, in collaboration with the University of Toronto, that now they can take a fairly modular approach to learning about it, being good consumers of it, figuring out what their role is in facilitating it, and they earn a university certificate at the same time in learning health systems. So this is a novel thing that we've done for the first time, and it's really for the health system partners to understand this whole way of working. It's a bit like the quality improvement work from the IHI, and it's really now just an extension of that work and leveraging the QI work that they currently all people in the institution have to take. But if you're interested in that, we can talk more about that as well.
Bit of a focus now on how do we take content and, like, to Shelley's point about what's the lay public language for this?
Yeah.
What's the frontline clinician language for this? What's the nurse? What's the physician? How do we build it into their expected training programs? What's the academic aspect of it? Learning about the science, and understanding what are the training elements? Because if we're actually going to move this, people need to learn.
Right.
And people can't all learn about it.
Another comment from Paul. It says he started off his academic career at Reid. Paul, if you want to unmute and say something, please feel free. It's really important to start off my academic career at Reid with Bob Brooks' team and work with Brian Nittman in information science. Williams, folks? Yeah.
Oh, yes.
Yes,
Absolutely.
Okay, great. So again, thank you for the presentation. Okay.
Okay.
Well, I can't thank you guys enough. It was a fantastic presentation.
Next time, how about you come to Toronto and visit us? And so we'll figure out a venue for
Carter of us.
we'll try to us. And then we have to spend some time in Toronto.
Yeah.
I'm scared.
Folks, just a couple, just a couple of quick announcements. Our next program is February 12th, 2025. We're going to be hearing from the Cerebral Palsy Research Network. It's a group that I am on the steering committee for. They have formed a national learning health system around cerebral palsy, and we'll hear about how that grew, how that's working out, and I just think it'll be a very interesting presentation. And then, how do we go to the next slide about evaluation?
Just post-event survey, if you have any feedback.
Can hit the URL there. I thought URL, QR.
Yeah.
Okay, thanks again.
Thanks.
So if you ever have any voters, let's speak out.
Thank you.
I know that.